What's up, Ninja Nerds? In this video today, we're going to be talking about metabolic acidosis. But before we get started in this video, please continue to support us by subscribing, hitting that like button, and commenting down in the comment section. All right, Ninja Nerds, let's get into this. All right, Ninja Nerds, so let's talk about metabolic acidosis, which is by far the most significant, most important acid-base disorder. When we talk about this disorder, it is crucial. One of the pivotal points in understanding this disorder is really understanding the etiology and the pathophysiology of metabolic acidosis. So let's go through these. Now, we're going to go through the diagnostics a little bit later, so I want you to trust me, but there's two different types of metabolic acidosis. There's a elevated anion gap metabolic acidosis, and then there is a non-anion gap metabolic acidosis. Now, there's a mnemonic that people love to throw around, right, for metabolic acidosis that has an elevated anion gap, and that's called mud piles. And that's great, but I like to keep it to the most common, most important things, and easy to remember, and that is CULT, K-U-L-T. So the first part of that mnemonic, K, is ketoacidosis. This is a very, very, very important one that I want you guys to remember. So ketoacidosis. Now, ketoacidosis, believe it or not, a lot of times we just say, oh, it's someone's diabetic, and that's why they're in DKA. And that could be the case, and that is going to be likely the more common cause. But it also could be due to two other reasons. One, if someone's taking a lot of alcohol, they're just guzzling that stuff down, that can cause a ketoacidosis. Or if someone's starving themselves, that can also cause a ketoacidosis. How? Let's explain that. So let's start off first with DKA. If someone has diabetic ketoacidosis, usually DKA is seen in someone primarily, more commonly, with type 1 diabetes mellitus, which means that they have a deficiency or a lack of insulin. Now, let's make sense of that. If someone has decreased insulin, what happens to the actual glucose levels within the blood? They go up, right? Because if you don't have insulin, you can't get the glucose from the blood into the tissue cells. And so as a result of that, you're not going to be able to utilize the actual glucose, and so your body starts tapping into other energy sources. So whenever there's this decrease in insulin, what happens is your body starts actually tapping into the secondary energy sources. What's the secondary one? Lipids. You know, within these fat cells, this is your adipose tissue, right? This is your adipose. In the adipose, you have triglycerides that are packed within these puppies, right? Whenever you have this decreased insulin, which means that you can't get glucose into the cells, which means that you can't metabolize it to make ATP, you tap into this lipid source and you start breaking down triglycerides. What is this called when you break down triglycerides? Lipolysis. So we're going to start increasing this lipolysis process. Now, when you do that, you break down triglycerides into two parts, right? One is the glycerol. We're not super concerned with that part. And the other one is the fatty acids. Now, what do the fatty acids do? The fatty acids will then start undergoing an extensive amount of metabolism, right? So if you have a lot of triglycerides, you'll break them down into a lot of fatty acids, and these generally will go to make acetyl-CoA. And the whole purpose of that acetyl-CoA is to make ATP, right? But if you have no glucose, because you have no insulin to get the glucose into the cells, you start breaking down tons of fat, you start having lots of fatty acids get converted into acetyl-CoA, that eventually the ATP starts going up, and this process of going through the Krebs cycle decreases. And what happens is the fatty acids, when they go through this process, what is this process when you take fatty acids and make lots of acetyl-CoA? This is called beta oxidation. What happens though is that too much acetyl-CoA accumulates, and it can't go into the Krebs cycle and make ATP. So it starts shunting into a different pathway. And this forms ketone bodies. And the two primary ones that I want you guys to remember are beta hydroxybutyrate and acetoacetate. These have the ability to act as acids. So beta hydroxybutyrate and acetoacetate are actually the conjugate bases of their corresponding acids, beta hydroxybutyric acid and acetoacetic acid. When they give off those protons, guess what that does? It lowers the pH. So these ketone bodies can give off protons and effectively lower the pH within the blood. When they lower the pH within the blood and it's due to a metabolic issue, that is metabolic acidosis. Okay? So that's the DKA effect. Now, what if someone is just chug-a-lugging, right? They're down in those Coors Lights or whatever it may be, and they're consuming lots of alcohol. As they start to consume lots of alcohol, the mechanism of this is, there's two ways. One is you actually can make a lot of acetyl-CoA. What's even more interesting with the alcohol is lots of alcohol, when it goes through its kind of metabolic pathway, it creates a ton of NADHs. Lots of NADHs have a very interesting mechanism. And what they do is, this process actually inhibits a process called gluconeogenesis. Now, if you inhibit gluconeogenesis, what does that mean? That means that you can't actually increase the blood glucose levels, okay? If you can't increase the blood glucose levels, what happens to the glucose levels? They're gonna drop. If your glucose levels drop, what does that do? You know that actually does a couple things. One is it's actually gonna stimulate glucagon production, and it's also gonna stimulate norepinephrine release. You know what these bad boys are gonna do? They're gonna come act on the adipose tissue, stimulate the adipose tissue to increase lipolysis, break down fatty acids to make acetyl-CoA. You'll make too many of them. They'll start shunting into this pathway and making ketone bodies, popping off protons and lowering your pH. Ba-boom. So we understand how alcohol does that. Another way is that if you have lots of alcohol, alcohol can actually get converted into acetyl-CoA too. So there can be another way, which also, if you want to think about it like this, alcohol can also be converted into acetyl-CoA, which will also increase that pathway. If there's too much acetyl-CoAs, it'll shunt into this pathway. The last one is starvation, and it's kind of a similar mechanism to alcohol. If you're actually starving, what's the kind of mechanism behind this? You're not eating. So if you're not eating, what's going to happen to your glucose levels? They're going to be lower, right? So you'll have low blood glucose. So in this kind of situation here, we can kind of combine these here. You'll have low blood glucose levels. Low blood glucose levels will trigger the glucagon, norepinephrine release. That'll cause lipolysis. That'll cause a lot of fatty acids to get converted into acetyl-CoA. Acetyl-CoA will get overwhelmed, can't go into the Krebs cycle, shunts into making ketone bodies, and drops your pH. We now know the three types of ketoacidoses would be DKA, excessive alcohol use, and starvation. And that's going to make up one of the primary causes of metabolic acidosis, primarily the elevated anion gap type. The second one, so we remember CULT, K-U-L-T. U is for uremia, okay? So this is for uremia. Now, uremia is whenever you have elevated levels of metabolic waste products due to an underlying kidney disorder. Now, this is important to remember. This uremia that we see in elevated anion gap metabolic acidosis is primarily an end-stage renal disease, so later renal failure. And we actually have to categorize this a little bit more, where particularly their GFR is actually less than 20. So if their GFR is less than 20, they have end-stage renal disease. That can be a cause. Now what does this actual uremia have anything to do with causing metabolic acidosis? We know your kidneys are responsible for filtering out particular types of metabolic waste products. You know what those are? There's three. One is sulfates. The other one is phosphates. And the last one is urate ions. So again, remember, sulfate is the conjugate base of sulfuric acid, phosphate is the conjugate base of phosphoric acid, and urate is the conjugate base of uric acid. All of those had the ability to release protons and become these conjugate bases, and these have the ability to lower your pH. So that's important to remember. When you accumulate a lot of these ions, and again, commonly you kind of correspond these with, this is the base, the corresponding acid is sulfuric acid. You give off that proton, it's going to lower the pH. Either way, if your GFR is so low that you can't clear and excrete these ions into the urine, they'll accumulate in the blood, give away the protons, and lower the pH. So that's the second one. The next one is by far going to be the most important type of cause that I really want you guys to remember. So we have K, U for uremia, L. So CULT, K-U-L, and this one is going to be lactic acidosis. So the next one that I want you to remember is lactic acidosis. Now, lactic acidosis, there's actually two types that I really want you to remember. The third type I'm not really concerned with you guys knowing. First one is type A lactic acidosis. Now this is due to a problem with oxygenation. Before we can even talk about that though, we have to kind of go through the basic physiology of the kind of the glucose pyruvate lactic acid pathway. So you guys know within our cells, right? You take glucose, right? Here's your glucose. Your glucose can get taken into particular cells of your body. And when it's taken into these particular cells of your body and it goes through the glycolysis process, it gets converted into pyruvate. Then what happens is pyruvate should move into your mitochondria. And you know within the mitochondria you have the electron transport chain. But either way, pyruvate will get converted, it'll get taken into the mitochondria and get converted into acetyl-CoA. And then it'll go through your Krebs cycle. And hopefully the end result out of this is it'll move to the electron transport chain and make ATP. That's the whole goal of the glycolysis and then the Krebs cycle electron transport chain. Now, what's the big thing to remember? Pyruvate, in order for it to be able to become acetyl-CoA, get into the actual mitochondria, what does it need? It needs oxygen. So let's represent that. We need oxygen in this process to be able to, for this process to occur. Now, if someone does not have the oxygen present to be able to convert the pyruvate into acetyl-CoA, what happens? It's a good question. I know you guys were asking that, right? Pyruvate will then get converted into a molecule called lactate. Now, lactate, again, is the conjugate base of corresponding acid, lactic acid. And again, lactic acid will give off a proton. That'll lower the pH and, again, make lactate. So it's the corresponding issue there, right? So again, if there is no oxygen, let's say low oxygen in this situation, there's no oxygen, then it's going to get converted into making lactate, okay? Now, if that happens then, why is the problem? What is the problem with this? Again, lactate, remember the corresponding issue is that it's related to lactic acid, and that lactic acid gives off a proton, becomes lactate, and then lowers the pH, causing a acidosis. So that's the big issue here. First type of lactic acidosis is called type A, and we said the issue is that there is no oxygen. So let's write that out then. What could be the reasons why someone would have a type A lactic acidosis? Let's go through these. And I want you guys to make it really easy on yourself. Don't make it hard, okay? What is the path of oxygen? First thing is it has to come into your lungs. So what if there's an issue where you can't get oxygen into the lungs and into the blood? What would that be? What would the problem be with that? There is a lung issue. So first thing I want you guys to think about is there some type of lung issue? Think about it simply. What if someone has COPD? What if someone has interstitial lung disease? What if someone has a pneumonia that you can't get the oxygen into the alveoli? They have fluid in the alveoli, like a pulmonary edema, or they have a clot in the pulmonary capillaries and you can't get blood to an alveoli to oxygenate the blood. Any of those issues are going to cause low oxygen in the blood. Low oxygen means that if you take a cell, for example, if I take a tissue cell here, here's my tissue cell, and I'm zooming in on all the cellular activities. I'm zooming in on it here. If I'm having a problem being able to deliver oxygen to this tissue, it'll start shunting into this pathway. One of those issues is that if I have low oxygen because of a lung issue. The second thing, oxygen has to go into the lungs and then go into the blood. And it has to bind onto what thing? Red blood cells. What if you have low red blood cells? What's that called? Anemia. So if you have anemia, that could also be an issue. Maybe it's because you're losing blood, or maybe you have some type of iron deficiency anemia. It could be various causes, but either way, there's low amounts of red blood cells to carry the oxygen. What's the red blood cells moving in to go deliver the actual oxygen to the tissues? It's moving in blood. So what if you have a low blood volume for some reason, or low circulating blood volume? So what would that be? If you have low, we'll put effective arterial blood volume, which means the amount of blood that's in the vessel, the amount of blood that's circulating through the vessel is lower. What would be reasons for this? Think about it very simply. Shock. If someone is in shock, go through the different types of shock. They're losing blood volume. Maybe they're dehydrated. That's decreasing their plasma. That's decreasing their effective arterial blood volume. Maybe they're losing blood. That's decreasing their effective arterial blood volume. Maybe their heart's not pumping well, and so they're not actually getting enough blood into the vessels, so they're in cardiogenic shock. Maybe there's something obstructing blood from getting out of the heart, like cardiac tamponade or a tension pneumothorax. Or maybe blood is actually getting out of the heart and circulating through the blood vessels, but the blood vessels are really leaky and dilated and fluid's leaking out. Septic shock, right? So if we think about those reasons, that'll help us to understand how this can lead to lactic acidosis. So a lung issue, a red blood cell issue, an actual circulating blood volume issue. To go to the next thing, what is the blood should be going to? It should be going in the blood vessels and taking this oxygen to the tissues. What if there is a obstruction or an occlusion within the blood vessel that the actual red blood cells and blood can't actually pass through? That could be a cause. So what if they have like an embolus? They popped off an embolus. So they have an embolism. Where could these be? In the leg, you get an acute ischemic limb. You get it in the belly, you get a mesenteric ischemia, right? Or you get it in the heart, you get a myocardial infarction. All right, so that would be kind of our type A lactic acidosis causes. Again, big thing to remember here, if you kind of want to put like a little annotation here, is that there is low oxygen or some type of oxygen impairment, if you will. Type B lactic acidosis has a couple different kind of types, if you will, okay? The first one for type B is that there's not a problem with oxygen. It could be an issue with the clearance of lactate. So you need to know what organs are primarily responsible for clearing lactate from the blood. So maybe you're making lactate at a normal amount, or maybe a slight increased amount. If you have normal kidneys, normal liver, you should be able to clear that lactate. But if they're all jacked up, what's going to happen? It's going to accumulate. So in someone who has an associated liver failure, so let's say here, I put like a liver here. I love you with all my liver. And that liver is all jacked up. That lactate should go to the liver and be cleared. But if the liver is impaired and it can't clear that lactate like it wants to be able to, lactate's going to build up within the blood. Okay? Lactate builds up, lowers the pH, causes an acidosis. To a lesser degree, if the lactate levels are very, very high and someone has an associated renal failure, the kidneys also do clear lactate, but if the kidneys are all jacked up and they're not able to clear that lactate like they want, what's going to happen? Usually the lactate should go to the kidneys and should get urinated out. But if the kidneys are all jacked up, what's going to happen? That lactate will not get cleared, it'll build up, lower the pH, and cause an acidosis. So the other thing to remember here is for type B, there's kind of subcategories to the type B, if you will. So type B, the first type, is there's no oxygen impairment, it's decreased clearance of that lactic acid. And the two types that I want you guys to remember here are going to be liver failure, and then the second one is going to be renal failure. Okay? The last type or subtype of type B lactic acidosis, because again, remember, type A is oxygen impairment. Type B is there is no oxygen impairment. So at the other aspect of this, so there's kind of like a subtype of type B where there's actually an increased generation. There's an increased production of lactic acid, right? Now this is a couple things, okay? One is that maybe the pyruvate can't get into the mitochondria because there's some medications that are really jacking up the electron transport chain, and so you just can't convert the pyruvate into acetyl-CoA, or you can't undergo the electron transport process of oxidative phosphorylation. There's a tons of meds. The ones that I really think are important, so meds that really, what they kind of do is they inhibit oxidative phosphorylation, and that really kind of screws up that pyruvate to acetyl-CoA process and instead shunts it to lactic acid. The big ones that I really want you to remember here is propofol. This is very common, especially in the ICU. Metformin, I can't express how important this one is to remember, especially even worse if someone has renal failure. So if someone they're taking metformin, which can cause an increased production of lactate, and you have a jacked up kidney, it can even worsen it. Okay, that's important to remember. The other one is if someone they're taking diazepam or lorazepam for seizures. And you know those contain lots of propylene glycol within them. So particularly within the benzodiazepines, like particularly diazepam, lorazepam infusions, that can cause it. The other thing is if someone has HIV and they're taking NRTIs, and then the last one is if they're taking linezolid for a MRSA infection. Okay, so just certain medications that you want to keep your eye out on that can cause this type of increased production of lactic acid. The other thing that I want you to remember is that maybe it's not just due to medications that are inhibiting this phosphorylation, but maybe you're also just having a lot of this glucose undergoing tons of glycolysis. So there's so much glycolysis that is going on that because of that, naturally this acetyl-CoA and Krebs cycle pathway gets kind of overloaded that you naturally just kind of shift to making lactate. And that's just because you're metabolizing so much glucose. So there's an increased glycolytic flux, if you will. This can be seen whenever there's an increased glycolysis kind of pathway. The big thing I want you to remember is seizures and also malignancy, particularly in conditions like leukemia, lymphoma, and multiple myeloma. Okay? So we talked about lactic acidosis. This is a very, very important one. I really want you guys to remember all of these. But this is going to be one of the big causes of metabolic acidosis. So remember I told you that there was a third type. If you really want to remember, it's called type D, and it's seen in short bowel syndromes where you're having a problem with the intestinal flora. Okay? So we have so far 3 parts of our mnemonic. K for ketoacidosis, U, uremia, L for lactic acidosis. What's the last one? T for on the last part of the cult mnemonic, and that's for toxins, right? So toxins. And this is where that whole mud piles mnemonic really kind of helps, but I just like to remember toxins, and then I like to remember MEPS. So what does MEPS tell me? It tells me the most important kind of toxic ingestions. First one is methanol, okay? Second one is ethylene glycol. The third one is propylene, and the last one is salicylates. Well, methanol actually gets converted into a molecule called formic acid. And again, formic acid has the ability to release a proton, and when it releases the proton, it lowers the pH. Ethylene glycol can actually get converted into what's called oxalic acid, or another one, glycolic acid. Glycolic acid. And again, they have the ability to release protons, lower the pH. Propylene glycol, we already talked about this. What does it do? It causes the type B lactic acidosis. And lactic acid will release a proton, become lactate, and that'll cause a lowering of the pH. Salicylates, what do? We didn't talk about that, but they're also another med that we can actually add into this list of type Bs. They also can cause lactic acidosis and lower the pH. Another thing that we talked about before, and I know you guys remember this, what else does it do? It increases your respiratory center and causes respiratory alkalosis. So don't forget that one, just as a quick reminder. But these are your big toxins that I want you guys to remember as causes of elevated anion gap metabolic acidoses. All right, so we talked about the etiology and pathophysiology behind the elevated anion gap metabolic acidoses. Now let's talk about the ones for non-anion gap metabolic acidoses, right? NAGMAs. So we use the mnemonic CULT, ketoacidosis, uremia, lactic acidosis, and toxic ingestions for the elevated anion gaps. For the non-anion gap metabolic acidoses, I like the mnemonic used cars, and then we'll explain how those things cause the acidosis. So the first one here, U, is actually ureterosigmoid ostomy. This is done in patients who have bladder cancer. And what they do is they remove the bladder and then divert the ureter into the sigmoid colon. And so what happens is, you know, your urine, you actually get rid of a lot of chloride and you get rid of a lot of sodium. Well, the chloride is the one that's actually the more pertinent one. And the reason why is the chloride, when it actually gets into the bowel, it actually gets absorbed across the GI tract. And when it gets absorbed across the GI tract, guess what actually moves into the bowel and then gets excreted from the bowels? So from the blood into the bowels, bicarb. So you're going to lose some of that bicarb in the stool because of this ureterosigmoid ostomy. And what happens if you get rid of the bicarb from the blood? So now think about this, decreased bicarb within the blood, right? What's going to happen there? that you're not going to have as many bicarb ions to counteract the protons. So now the protons are going to increase. If the protons increase, what does that do to the pH? That will lower the pH and cause an underlying acidosis. Okay? So that's the first one. So U, ureterosigmoidoscopy. The next one, S, saline infusions. This is very common. Okay, I see this a ton in the ICU, is you're giving someone too much normal saline infusions, or even more significant is you're giving them hypertonic saline infusions. Why is this a problem? So I like to remember S, so saline infusions. Now, the two big ones are going to be your normal saline, and then the second one is going to be your hypertonic saline. Either way, both of these contain large amounts of chloride. When you increase the amount of chloride, what happens is you actually kind of effectively decrease the bicarb. Okay, so whenever you increase the chloride, you effectively decrease the bicarb. And that decrease in bicarb, there's less of those protons to be counteracted, right, by this bicarb. And so that's going to do what to the pH? Lower the pH, okay? So you see this in normal saline infusions and hypertonic saline infusions. The next one, so used, E, is renal failure, but here is early renal failure. In the elevated anion gap one, it was late renal failure or end-stage renal disease. So it's important to remember that particularly in early renal failure, this would be a cause of a NAGMA. Now, how is this one different? Well, this situation is primarily because the kidneys have a decreased ability to generate bicarb. So there's decreased bicarb production. If there is a decrease in bicarb production from the kidneys, what happens there? Then you can't actually counteract the protons. If you can't counteract all those protons, that lowers the pH. You guys are starting to get the point here, right? Okay, use D, diarrhea. So if someone is just painting the town brown, if they're restocking the lake with brown trout, if they got the Hershey squirts and they're blasting this out, they're losing what? You know, within the intestinal secretions, what is the primary thing within the intestinal secretions? It's bicarb. You know, your intestinal cells, they make lots of bicarb to counteract the acidic environment of the stomach. That could be one reason. If you're having diarrhea, you're losing a lot of that bicarb from those intestinal secretions. But there's one other thing. You know the pancreas, right? The exocrine portion of it, the acinar cells, they're helping to make bicarb. And so sometimes if someone has a pancreatic fistula, that's having a direct connection between the pancreas and the actual intestines, that can just dump a lot of bicarb from those pancreatic acinar cells or the ductal cells there, and they can also lose a ton of bicarb that way. So two ways upon which you can actually have a metabolic acidosis from this associated GI tract problem here is if they have primary one, D, diarrhea, okay, and the whole mechanism behind it is that you're losing bicarb. So if there's a decrease in bicarb in the blood, what's going to happen? That's going to decrease the pH. But the other associated issue to not forget about, just because they like to throw it in there sometimes, is you can also, if you want to, add in there pancreatic fistula, especially if someone had a history of pancreatitis. Okay, so we have used, now we got to go to the CARS portion. So C is actually if someone was on a particular medication that causes you to get rid of bicarbonate in the urine. You know what this condition is? Where you actually get rid of bicarb in the urine. So tons of bicarb is going to get lost in the urine. This isn't whenever someone is taking carbonic anhydrase inhibitors. What is the primary one here? Acetazolamide. So if someone is taking acetazolamide, that actually works by acting on the renal tubular cells and causing them to lose bicarb. If you lose bicarb in the urine, what happens to the bicarb in the blood then? You have decreased bicarb in the blood, less of this bicarb to counteract the protons in the blood, and that'll lower the pH. Okay? So we've gone through used C, so now we have R's, right? The next one is kind of a double whammy, okay? So I'm going to combine A and R because they're kind of together. So the next group of conditions that I'm going to combine with the A and the R is called renal tubular acidosis. Okay, to make it easy though, I'm just gonna put over here on the side the A, just to be consistent here. The A is for Addison's disease, and it is a type of renal tubular acidosis, particularly type 4. And then the R to the CARS is going to be the renal tubular acidosis. So that's why I'm combining them, is because Addison's disease is actually one of the types of renal tubular acidosis. So they go together. So let's go through these. Renal tubular acidosis, there's 4 types. Type 3 is not that big of a deal, and it's actually very rare, so we're not even going to talk about it. We're going to talk about type 1, 2, and 4. So let's start off with kind of the types based upon their location within the kidney tubes. I think it makes most sense and it's easier to remember. So here you have this 2 symbol, so we're talking about renal tubular acidosis. Type 2 renal tubular acidosis primarily is a problem where there is an issue in the proximal convoluted tubule. So let's write that down. So type 2 renal tubular acidosis, the issue is in the proximal convoluted tubule. Well, what is the problem in the proximal convoluted tubule? I'm so glad you guys asked. What happens is the PCT is responsible for reabsorbing tons and tons of molecules, but one of the big ones that causes this issue is bicarb. They can't reabsorb bicarb for some reason. So because of that, there is a decreased reabsorption of bicarb. And so instead of actually reabsorbing the bicarb here, what do? You lose all of that bicarb into the actual kidney tubules, and you'll urinate that bicarb out. So where's the bicarb actually going to end up? It's going to end up in the urine, and you're getting rid of the bicarb. So if you decrease your reabsorption of bicarb, what does that do to the bicarb in the blood? It decreases the bicarb in the blood. What does that do to the pH? Well, you don't have enough bicarb to counteract the increased protons. And what is that going to do to the pH? It's going to lower the pH. Okay? One other thing you guys need to remember. This is a really interesting one. Whenever you have a lot of bicarb that's kind of getting pulled through the kidney tubules, it does have an osmotic gradient with it. So whenever it moves through the kidney tubules, down like the descending limb, the ascending limb, so on and so forth, and then gets down here to the urine, you're also going to lose a lot of stuff with it. You know what you lose with it? It actually pulls sodium and water. If you pull off sodium and water, what do you think that's going to do to your blood volume? It decreases the blood volume. What does that do to your kidneys? You know what it stimulates? Your JG cells. What do? They love whenever you have low blood volume, they make renin. Renin then does what? You stimulate the renin, angiotensin, aldosterone system. Aldosterone does what? Acts on the distal kidney tubules and causes you to get rid of potassium. So what else will be a result out of this if you stimulate this pathway? You'll have low potassium. Can't express how important that is. So in type 2, you'll have decreased reabsorption of bicarbonate in the PCT and loss of potassium ions. Okay? The next one, type 1 renal tubular acidosis. Let's do a different color just to be interesting and purdy, right? So type 1 renal tubular acidosis primarily affects the distal tubules, right? So more like your distal convoluted tubule and your collecting duct areas, okay? But particularly what cells of the distal tubules is what I want you to remember. I want you to remember the alpha intercalated cells. You know the alpha intercalated cells are responsible for secreting protons? Guess what these guys do? They don't excrete protons. So because these are all jacked up, there is a decreased proton excretion from these alpha intercalated cells. If you don't excrete protons into the urine, what happens to the proton concentration in the blood? It's going to go up. So there's going to be an increase in proton retention in what? The blood. And if you increase the proton retention within the blood, what does that do to the pH? It drops your pH. Here's something very interesting though. You have 2 types of kind of pumps at the alpha intercalated cells. One is a proton ATPase pump, and the other one is a proton potassium pump. So for example, if I had like a cell here, and here was that portion of the cell. Here's going to be one pump that pumps out the proton into the filtrate, and the other one will pump the proton out and bring the potassium in. Both of these pumps aren't working. So if I can't pump the proton out, guess what I also can't pump in? Potassium. And so guess what else happens as a result of this? There's also going to be potassium excretion. So increased potassium excretion. And what does that do to the serum potassium? That lowers the blood potassium. That causes hypokalemia. So same thing. Low potassium in the blood for type 2 and low potassium in the blood for type 1. Okay? The last one, which is going to be this Addison's disease type, is type 4. Let's do another pretty color here. Let's do this red one here. Type 4 renal tubular acidosis. This one is a problem again with the distal tubules. So those distal tubules are all jacked up. And primarily it's both. So we're going to actually kind of abbreviate these. So if it's the alpha intercalated cells and the principal cells are jacked up, okay? We already kind of know what happens with the alpha intercalated cells, right? With the alpha intercalated cells, what are you going to do? You're going to decrease your proton excretion, and we already know what that does. It leads to a lower pH by retention of protons. So that part's already done. That's one way that it contributes to the acidosis. Something else happens though. Whenever you work on the principal cells, what does it do to the principal cells? Aldosterone normally should do what? It should actually cause what process? It should act on the principal cells and increase the reabsorption of sodium and excrete potassium. In Addison's disease, guess what the problem is? You have low aldosterone, and maybe even other. It's the failure of the entire adrenal cortex. But aldosterone is also one of those hormones that's going to be whacked off, right? So because of that, you're going to have low aldosterone. Okay? If you have low aldosterone, think about what it'll do to the principal cells. You're going to have less sodium reabsorption. So what's going to happen to the sodium then? If there's decreased sodium reabsorption, there's decreased sodium in the blood. And what else? It's normally supposed to cause potassium excretion, but you're not getting rid of the potassium. So if you don't get rid of the potassium, what happens? It accumulates in the blood. So the potassium will rise in the blood, and this will cause hyperkalemia. Okay? So with this combination of effects in type 4 renal tubular acidosis, you affect the distal tubules, you decrease potassium excretion, causes proton retention, lowers the pH. You also don't reabsorb sodium into the blood, and you get rid of potassium, and so potassium will rise within the blood. Okay? So these are the different types of renal tubular acidosis, which can help us to finish the A and the R portion of our mnemonic of used cars. There's one last one. And this one is kind of like the lower end of the list, but just to throw it in there for you, it's supplementation. So used cars, the S part is supplementation. So supplements, and the primary ones that I want you to remember is TPN. So total parenteral nutrition. This is happening in patients that you need to feed, and what happens is whenever you're kind of giving them these calories, if there's too much chloride or there's too much acetate, these can cause problems, right? Because whenever you have an increase in chloride, you're going to be getting rid of bicarb. So there's a loss of bicarb, right? So this decreases your bicarb. And what does that do? When you decrease bicarb, you have less bicarb to interact with the protons, and that lowers the pH. So again, whenever someone is getting hyperalimentation or their TPN is containing lots of chloride, lots of acetate, that can also cause anagma. This pretty much gives us all the etiologies and pathophysiologies of both NAGMA and AGMAs. Let's talk about the workup and diagnosis. All right, so now that we've really kind of built the foundation for understanding metabolic acidosis, we talked tons about etiology and pathophys, it's really going to make diagnosis and kind of workup portion of this very, very straightforward, simple, and understanding. So how do we kind of go through our diagnosis or workup of acidosis? Well, first thing we need is an ABG, because it's going to help us to determine what type. Is it a NAGMA or AGMA? And then we can kind of go down those lists. So first thing is, let's look at our ABG here. We have a low pH, right? Why? How do I know that? Well, normally it's 7.35 to 7.45. That's way less than that. That's down. PCO2, well, normal is 35 to 45. That's less than 35. That's down. Bicarb is 22 to 26. It's less than 22. That's down. And then O2 is within normal range, 80 to 100 millimeters of mercury, right? So no hypoxia. So with that being said, remember what we told you. Whenever SMORE, right? Whenever the pH is moving in the same direction, it's metabolic. It's a primary metabolic acidosis. Let's write that down. This is definitely a primary metabolic acidosis. But let's try to make sense of this CO2 thing, right? Let's be consistent with what we've learned so far. If this is an acidosis, what does that mean? That means that the pH is low. What does that do to your respiratory system? Well, it tells the respiratory system, hey, pH is really low. Let's try to breathe off some of that CO2. Why? Because let's make sense of this. If I take CO2, right, and I use my equation, CO2 plus water yields carbonic acid, and that breaks down into protons and into bicarb. Let's make sense of this. If I start breathing faster and deeper, I'm blowing off the CO2. The CO2 levels within the blood will drop. What does Le Chatelier's principle say? You have to move things to keep the reaction kind of stable or in equilibrium. So if it's lower on this side, the reaction is going to have to shift towards the left. When you do that, you use more bicarb and protons to combine and make carbonic acid and then help to convert and make more CO2 and water. So what does that do to the amount of protons then if you're shifting this towards the left? It decreases the amount of protons. And that's trying to help to compensate for that low pH. So there's definitely some respiratory compensation here because you're trying to breathe that CO2 off. So we would say this is a partial respiratory compensation. Okay? Next thing, I determined that it's metabolic acidosis, right? There is some respiratory compensation. The next thing is I need to know, is this an elevated anion gap or a normal anion gap? How do I determine that? I got to get my BMP. So from my BMP, what am I going to take from my BMP? I'm going to take my sodium and I'm going to take my chloride because I have my bicarb from my ABG. So let's say that sodium from this BMP is 129, okay? Your chloride is 100. So if I take, and what's my equation for the anion gap? So the equation, if you guys remember, is anion gap is equal to sodium minus chloride plus bicarb. So if I take this and utilize this equation then, anion gap, all my numbers, is equal to what? Sodium is 129 minus the chloride here, which in this case is 100, plus my bicarb, which is 11. What does that give me? That gives me an anion gap of 18, okay? Now, what is a normal anion gap? Usually it's less than 12. If this anion gap is greater than 12, it's considered to be elevated. So in this case, this is definitely a AGMA, elevated anion gap metabolic acidosis, right? But if there was an anion gap that was less than 12 in this situation, that would definitely be a NAGMA. But if it's greater than 12, that would be a AGMA. Okay, so in this example, we knew it's a primary metabolic acidosis. We used our anion gap to determine that in this case, it's definitely an AGMA. If it was less than 12, it would be a NAGMA. The next thing we want to determine, is this a pure AGMA, a mixed AGMA, or is there some other concomitant condition there present? Do you guys remember your delta ratio? Delta ratio, you'd have to calculate out, you take the anion gap that you actually calculated minus the normal divided by the normal bicarb minus the bicarb that they have and get a ratio. Generally, if the ratio is, you have a couple options here, less than 1, you have 1 to 2, and you have greater than 2. If it's less than 1, it's an AGMA and NAGMA. If it's 1 to 2, it's just an AGMA. And if it is greater than 2, it's an AGMA and a metabolic alkalosis. So if we were to actually calculate all of this out, you take, for example, 18 minus 12, divide that by 24 minus 11, it's going to be less than 1, okay? So this person has a AGMA and a NAGMA in this example here. So we figured out so far kind of how we would go about doing this. So first step, get your ABG, determine the primary condition. If it is a metabolic acidosis, determine the anion gap. If it's elevated, you go on to determine the delta ratio. okay? And now, so far, we've kind of determined that there's a mixture. Either way, once we've got up to this point of the anion gap, that's pretty much all I really need to start my algorithm. All right, so I know this wasn't here before, but I wanted to draw this kind of like flow diagram algorithm process that we're gonna go through to make it look pretty so it doesn't get too messy when we're kind of going through it on the fly. But I really think that this algorithm is really gonna make sense of everything that we talked about over here, trying to figure out the cause and the etiology. So let's go through this. We suspect someone has metabolic acidosis based upon their ABG. We get our BMP, we calculate our anion gap. If the anion gap is elevated, what do I mean by that? By it's greater than 12, then that means that the person probably has an anion gap metabolic acidosis, which has the differentials that we talked about before. And what were those differentials? KULT, ketoacidosis, uremia, lactic acidosis, or toxic ingestions. If the anion gap was low or normal, meaning that's less than 12, that may be associated with a non-anion gap metabolic acidosis. And then again, we have our used cars as the particular type of mnemonic to remember all those. Let's go through the labs and different types of things that we would go to figure this out. First one, K for the cult part. What do I think of? Ketones, so ketoacidosis. So I'm gonna check the ketones. And you can do this by checking the serum ketones, you can check the urinary ketones. Either way, if the ketones are positive within the serum or urine, you can suspect potentially this is a diabetic ketoacidosis, an alcoholic ketoacidosis, or maybe even a starvation type of ketoacidosis. Again, go through their underlying cause. Maybe they're hyperglycemic, they have diabetes, they've been drinking alcohol, or they've been on a special diet lately. Okay? If the ketones are negative, maybe then it's not a ketoacidosis. Instead, it's one of the other parts. So uremia, lactic acidosis, or toxic ingestions. Okay, so I think of lactic acidosis as the next one. I'm gonna send off a lactate level. If the lactate is elevated, and we'll just put positive in that sense, greater than like 4, like milliequivalents, then I would say, oh, lactate's a little elevated. Maybe they have an underlying lactic acidosis. And again, with lactic acidosis, you have to figure out the type. Is this a type A issue where there's an impairment in oxygen, or is this a type B issue, meaning that there is no impairment in oxygen and there's some type of increased production or decreased clearance of that lactate, okay? So once I've done that, okay, that could be the cause there. Now go through the next one, maybe uremia. So we did ketoacidosis, we've done lactic acidosis. What about uremia as a potential cause? Well, again, if I have my BMP, I can use the creatinine and the BUN from that, right? So if they have like an elevated BUN, if they have an elevated creatinine, and maybe their baseline GFR is low, like less than 20. What can I associate that with? Maybe there's a renal failure. And so if there's some type of renal failure, again, if it's kind of like late end-stage renal disease where the GFR is less than 20, it's more likely to be end-stage and cause the AGMA. But if it's early where there's an impairment in bicarbonate production, maybe it could be a AGMA. And we'll talk about that a little bit later, so because this can actually have kind of a side pathway. All right, next thing. I could also assess, what if this person has had a toxic ingestion? So I go to the last part of my mnemonic, toxins. So I run a tox screen. If I do a tox screen and it comes back positive, maybe I think that they have an ingestion. If I suspect an ingestion, what do I do? Oh, well, what do I do, Zach? Do I order every single one that I think about? No. What you can do is you can order what's called an osmolar gap. Now, this isn't always the best, but it's helpful to think about. Osmolar gaps is a particular calculation. You base it upon the person's BUN, their sodium, their glucose, their alcohol level, and you form a calculation. We're not going to go through all of it, but based upon this, you take whatever you calculate and you actually use a particular equation from the actual measured serum osmolality, and you subtract the difference between them. If the difference between the calculated and the measured is greater than 10, then it's most likely indicative of toxins of that MEP part, right? So we had MEPs. This is the first part, MEP. So methanol could be one, ethylene glycol could be the other, and propylene glycol could be that last one, if the osmolar gap is greater than 10, okay? If the osmolar gap is less than 10, right, so the calculation between the serum and the measured osmoles is less than 10, then you start thinking about salicylates. Okay? And that's how we would kind of go through that whole list that we did with the elevated anion gap. We've done that. Now we go through the non-anion gap metabolic acidoses. So the first thing I like to do is I like to think about this as, is the person getting rid of particular types of molecules like protons or bicarb, and it's affecting their urine? Are they having issues with their urine, or is it a GI or other miscellaneous issue? That's the first thing I want to know. Is it a renal cause or some other extra renal cause? So the first thing I do is I order a urine anion gap. So if I check the urine anion gap, and it's kind of like the same thing, you take sodium, urinary sodium, plus the urinary potassium, and you subtract the urinary chloride. All urine anion gap tells you is if the person is getting rid of, so here's what I want you guys to remember. Urine anion gap, I want you to kind of associate this with the amount of ammonium that is being excreted by the kidneys. If the amount of ammonium that is being excreted by the kidneys is decreased, the urine anion gap will go up, okay? And this means that this is a renal issue, okay? So if the urine anion gap is positive, that means that it is what? Greater than 0, elevated. That means that you're not getting rid of ammonium, okay? So this makes me think of renal causes, okay? If the urine anion gap is negative or less than 0, that means that there is ammonium being, so a low urine anion gap, that means that the ammonium is being excreted and the kidneys are working fine. There's probably some other extra renal issue that's a cause. So we can put here that there's maybe an extra renal causes. Okay? So now that I've done that, I start thinking about the renal causes. The first one that I can go right into, check their BUN, check their creatinine, check their GFR. If the BUN creatinine is bumped up, if the GFR is low, it could be renal failure. So that was one of them. The other part is you think about all those renal tubular acidoses, right? There was a bunch of those. So if I think that this is a renal tubular acidosis, the next thing I do is I check the potassium, because that was one of the big things that I talked about with you guys. What if I check the potassium and the potassium is elevated? So I check the potassium and they have high potassium. If there's high potassium, they have a NAGMA, I may want to start thinking about a type 4 renal tubular acidosis. And I can go and confirm that by looking to see if they have maybe low aldosterone levels, low cortisol levels, so on and so forth, right? But again, that's one of the big things here. If I check and their potassium is low, then I have type 1 or type 2. How do I differentiate those? Do you guys remember? So let's go back to type 2. Type 2 renal tubular acidosis, what was the issue? It was with the PCT, and what were you not able to do? You weren't able to reabsorb bicarb, so you lose bicarb in the urine. So what do you think the fractional excretion of bicarb in the urine is going to be? It's going to be high. It's actually going to be elevated. Sometimes we say greater than 15%. Not super important, but it's going to be high. The other thing is the urine pH. Where's the problem? Okay, you're not able to reabsorb bicarb. Is the alpha intercalated cells working though in the distal tubule? Yes, those are still working. You didn't damage those, you only damaged the proximal convoluted tubule. So your alpha intercalated cells can still make protons and release those protons. So your urine pH will still be relatively normal, so maybe like less than 5.3. So the urine pH, it can vary, but it's usually kind of less than 5.3. Compare that with the type 1 renal tubular acidosis. What's the issue? The problem is that you have an issue being able to excrete protons in the urine. If you have a problem excreting protons into the urine, what do you think the urine pH is going to be? Well, not putting a lot of protons into the urine. Is it going to be less than 5.3 or greater than 5.3? It's going to be greater than 5.3 because I'm not putting a lot of that protons into the urine. And then am I getting rid of a lot of bicarb? No. So my fractional excretion of bicarb is going to be low. You see how those can differ? They both have hypokalemia, both have anagma, but their urine pHs differ and their fractional excretion of bicarbs differ. Okay, we figured out our renal tubular acidosis, right? Now we come over here, we have our urine anion gap, it's negative. We got to think about extrarenal causes. This is where you just have to dig into their clinical history, right? Dig into the clinical history. So go through some of the issues go through some of them that mnemonic. Let's see if we can figure out which ones we have left over. First one, used cars, ureterosigmoidostomy. Do they have that? That's a simple thing, right? Look into their surgical history. So first thing is, do they have a ureterosigmoidostomy? That's the first one. Second thing, we go down. S, are they getting saline infusions? Next one, E, do they have any early renal failure? We already hit that part, okay? D, do they have any diarrhea or a pancreatic fistula? Okay? C, are they on any kind of carbonic anhydrase inhibitors? Are they taking acetazolamide? R, do they have renal tubular acidosis? We already talked about all of those. And Addison's disease, we talked about that one. And then the last one here is, what else? Supplements. Are they getting any type of TPN? Once I figure out all of these other things, it's just kind of going through my mnemonic and filling in any parts that I missed. And that'll cover your entire workup for being able to figure out and pinpoint the cause or the etiology of metabolic acidosis. Let's finish it up with talking about the treatments. All right, Ninja Nerds, we have drilled home how to really figure out the differential diagnosis, how to work it up. Let's talk about the treatment. Now, we're not gonna go ham bone because each of these individual, you have to treat the underlying cause. So to treat the underlying cause, you have to figure out what that cause is. We're not gonna go crazy into each treatment of every single thing. I just want you to know the basic points. What's the overall treatment goal for these patients? So the most important ones that are relatively reversible and that you should try to take care of first, I want us to focus on. Ketoacidosis is one of those. So in ketoacidosis, it depends upon the cause, right? So if they have diabetic ketoacidosis, what's the mainstay of treatment for that? It's primarily three things that I want you guys to remember: IV fluids, insulin, and then their potassium. You got to give them back potassium, especially if you're giving them insulin, because there's shifts of potassium there. If they're having alcoholic ketoacidosis, you want to give them fluids back. That's definitely important. You actually want to give them glucose, so you give them dextrose because they're going to be hypoglycemic. You also want to give them B1 and B9, so thiamine and folate, because they also lose that because they're not getting it from their diet. And the other thing that you want to give in alcoholic ketoacidosis is you want to replace a lot of their electrolytes, so potassium, magnesium, and then the phosphates. You got to replace those. And then also be careful, if someone is a very dependent alcohol user, they can go through the DTs, delirium tremens. So you may have to give them some benzos to prevent that as well. But either way, that's not at the pinpoint thing that I want us to focus on. And the last one is starvation ketoacidosis. It's pretty much IV fluids and giving them back some sugar because they haven't really eaten anything. Okay? And you may have to also replace some of their electrolytes as well. Renal failure. With this one, you can try to, again, figure out the underlying cause. If it's kind of an early renal failure, there's like an acute kidney injury, and you can try to treat the underlying cause of that acute kidney injury, like if it's a pre-renal, giving them fluids, treating their CHF, treating their cirrhosis, whatever it may be. If you can fix those things, fix it. But usually, if it's very severe, at this point, when someone has severe, let's actually put severe renal failure, sometimes this may lead to the person having to be on continuous renal replacement therapy. Usually this is very important in patients who are like hemodynamically unstable. Or you can do what's called intermittent hemodialysis, and this is better in patients who are hemodynamically stable because you pull off a lot of fluid on those, okay? So again, if you can try to figure out the cause of the renal failure and it's early, try to fix that, but if not, and if it's a little bit later, it might lead to these kinds of unfortunate things like hemodialysis or renal replacement therapies. If someone has lactic acidosis, again, there's too many things to go through. We're not going to go through all of them. I just want you to go back and think. We're going to kind of quickly recap it. If it's type A, fix the issue. So is it a lung issue? If it's CHF, give them diuretics. If it's pneumonia, give them antibiotics. If it's some type of COPD exacerbation, treat the COPD with steroids and Duaneb, so on and so forth, right? If it's an embolism, a PE, give them heparin or TPA. It's the simple thing, right? If they're anemic, so if they have anemia, give them a transfusion. If they have a decreased effective arterial blood volume, figure out the cause of that. Are they hypovolemic? Give them fluids. Are they losing blood? Give them blood. Is their heart not working? Give them inotropic agents. Is there a tension pneumo or a cardiac tamponade? Do a pericardiocentesis or a chest tube. Is there septic shock? Give them antibiotics and pressors, right? Is there an embolus somewhere? Maybe you have to go and do an embolectomy. So once you figured that out, you treat the underlying cause, it should help hopefully resolve. The other one is your type B, right? And for this one, you got to think about it, right? What was the big thing? There's an increased generation. Maybe you have to discontinue all those terrible offending medications that were causing it. The NRTIs, the linazolid, the propofol, the propylene glycol, right? The metformin, all of those things, get rid of them. Or maybe at least decrease the effective dose of them. And then the other one is if someone is having seizures and they're having a lot of glycolytic flux, that may also be a reason. So maybe you have to give them some benzodiazepines. And if they have some type of underlying malignancy, like leukemia, lymphoma, or multiple myeloma, you may have to treat that as well. So a lot of stuff within this category. We're not going to go through every single treatment. Just think about the cause and treat the underlying cause. Toxic ingestions. These ones I actually do want you to remember because these are relatively high yield. So toxic ingestions, the big ones that I want you to remember is methanol and ethylene glycol. These you actually do give fomepizole. There's a drug called fomepizole, but this is primarily if it's early. So if someone has really just recently taken a lot of methanol or ingested ethylene glycol, you can give them fomepizole, but if it's late, it's usually hemodialysis to pull that stuff off, okay? The other one is, since we did these, we'll just mention the other one, propylene glycol. Remember I told you about this one? It was within the infusions. If someone's getting like diazepam, lorazepam, or like a phenobarbital or something like that, like an infusion, you just discontinue it. Stop taking it, okay? And if it's really bad, then you might even have to do hemodialysis. And the last one is salicylates, okay? And this one, you give sodium bicarb to them, and then sometimes if that doesn't work, you may even have to do hemodialysis. So again, this one doesn't work, hemodialysis. Alrighty, the last thing that I want to talk about, which is a very controversial topic with respect to metabolic acidosis, is do you give them sodium bicarb? All right, it's very controversial. I mean, the reason why is that there's actually not been a lot of good research, like evidence, that shows that sodium bicarb can help to treat acidoses, especially ketoacidosis and lactic acidosis. There actually hasn't been much benefit for it. However, still some people believe in it, right? So again, sodium bicarb can be one of those that can be utilized. And it can be given in two ways. If it's acute acidosis, sometimes they'll give this as an IV kind of like infusion. And we're not going to go through all the calculations. That's not necessary here. If it's chronic, it may be given in like tablets. So sodium bicarb tablets, okay? So that's one thing to think about. Now, the big thing to remember with sodium bicarb is that whenever you give sodium bicarb, the problems, why people are very worrisome about it is that if you give this, you're giving a lot of sodium, so it can cause hypernatremia. You can also lower someone's calcium, cause hypocalcemia, and increase their CO2. And this can cause a lot of cardiovascular problems. So again, when someone gives sodium bicarb, there is a lot of complications, and there hasn't been much benefit in the literature to see its effect in lactic acidosis and diabetic ketoacidosis. But still, sometimes it can be utilized. The last one that also can be sometimes utilized, especially in a person who has metabolic acidosis and respiratory acidosis, is a drug called tromethamine, abbreviated THAM. So THAM is basically kind of a proton acceptor, and so it picks up any protons from this acidic environment within the blood. And this, again, is particularly beneficial in patients who have metabolic acidosis and associated respiratory acidosis. So you give this to people who have very high partial pressure of CO2 levels in the blood. Okay, this is actually seen to be a little bit more beneficial in those scenarios. So this covers the treatment of metabolic acidosis and finishes our lecture on metabolic acidosis. All right, Ninja Nerds, in this video, we talk about metabolic acidosis. I hope it made sense. I hope that you guys enjoyed it. And as always, Ninja Nerds, until next time.